Hello, and welcome to today's webinar, Scaling New Models of Care Delivery, Culture Eats Strategy. My name is Tammy Harris, and I will be your moderator. Before we start, I want to ensure that everyone is familiar with the webinar control panel. First, you should have a control panel on the right side of your screen. You can minimize and expand this panel by clicking on the button in the upper left corner. Second, you can submit questions using the chat panel located near the bottom of the control panel. We really want to hear from you and encourage you to ask questions. We will answer as many questions as we can during the Q&A. If your question was not answered, we will respond to you individually after the webinar. Last, all registrants will receive a copy of the presentation as well as the recording. Now let's get started by introducing our speaker. Dr. Terry Lee Mills is the Medical Director for Patient Care Systems, Via Christi Health, and Chair of the Family Medicine Department for Via Christi Clinic in Wichita, Kansas. Via Christi Health is the largest provider of healthcare services in Kansas, offering services through 5 hospitals, integrated multi-specialty clinic, senior villages, and related health services. Dr. Mills attended medical school at the University of Oklahoma College of Medicine and completed his residency in family medicine at McLennan County Medical Education and Research Foundation in Waco, Texas. Driven to advance information and care delivery systems in order to improve the quality and experience of care for patients and healthcare providers alike, Dr. Mills was named a 2013 Healthcare Hero by the Wichita Business Journal. Dr. Mills is certified by the American Board of Family Medicine with a certificate of added qualification in hospice and palliative medicine. And now I'd like to welcome Dr. Mills. Dr. Mills?
Thank you, Tammy. I appreciate FITEL's opportunity to reprise this talk that was given at the FITEL Executive Summit about a month and a half ago. And welcome to friends and colleagues all over the country. I originally became interested in this topic of how culture affects our day-to-day work after a whole series of experiences like many of you. Here at Via Christi, I am deeply embedded in medical director for a CMS Center for Medicaid Medicare Services Innovations grant about the medical neighborhood with TransferMed, and have been responsible for driving our medical home pilot. And had a whole number of encounters with good physicians and colleagues where there were opportunities and data led to clear assumptions of next steps, and yet physicians responded in very negative and unhappy ways. And it just led me to start thinking about what is it about this work they're doing that leads physicians to be so unhappy and resist change. So any of you that find that your physicians rush towards change and are eager to be first in line, this may not be the talk for you. Importantly, realize I don't claim any special insight or dramatic expertise. I'm just an interested observer along this journey together towards clinical improvement, population health, and value-based healthcare. And so in one sense, this is really just a travelogue. It's sites that I've seen in my journey in healthcare delivery over the last 3 years or so. In another sense, I'm just a fascinated student of us, of healthcare, of taking care of real patients, and have been a keen observer of just what makes us tick. And just when I think I've gotten physicians and leading physicians figured out, I have the opportunity to rethink that assumption. And that's often a bit painful or embarrassing or both. And then lastly, I can say that I'm married to a child psychologist, and happy to report that after 26, 27 years of daily intensive therapy, I'm feeling better most days. But that brings me a bit of introspection to our daily work. It is always good to remain interested and curious about the world around you, about our patients, and about our physician colleagues. And so that leads to our agenda today, which is to set the triple aim stage very briefly, then to highlight the paradigm changes the triple aim is going to require of healthcare. I'd like to review the concepts of adaptive versus technical change, explore physicians from an outside view, looking at just kind of a cultural subgroup. I'd like to discuss in 3 ways of understanding resistance to change, and then propose a way forward, taking advantages of some of those theories of change. And now sometimes I may sound like I'm coming down kind of hard on our physician colleagues and partners, and truly I'm not. I'm just trying to take a clear-headed perspective on why in many of our cultures the race towards improvement is in value-based healthcare, population health is not an easy change. I find this emblematic of where we are today in healthcare. We build a wonderful, beautiful bridge, a marvel of construction for an environment that is suddenly, dramatically, and unreversibly changed. We have a fantastic care system when what we really need is a health system. So if we don't adapt to the changing conditions, build the structures that are needed for tomorrow, we might find ourselves useless, like a bridge without a river, bypassed upstream or upmarket by more flexible, more adaptive systems, and disrupted downmarket by ferry boats and swimmers. The healthcare environment has finally coalesced around a set of goals clearly enunciated by IHI as the triple aim. Of course, improving patients' experience of care, the health of populations, and reducing the cost. I especially like the version that includes the +1, which is improving the experience of care for those providing the care. And that's an important aim to include because our systems of care are so complex and so difficult, and they take tremendous energy to get the machinery to mesh, that improving experience of care by reducing complexity is often an early win and a way to get buy-in from your teams. The tipping point has truly been reached in America where the economics mandate something different, and that is to say, quoting Gladwell, basically that the pain of status quo has finally exceeded the pain of change. And that's the first time that has happened in generations in U.S. healthcare. And so that is really a fundamental truth that most people on the call probably clearly understand. But I find that some of our physicians and administrators don't yet fully understand or accept that. It is important, though, that from that bedrock assumption that really the purpose of health and healthcare is larger than just the care of one individual at a time, it is from that bedrock that you quickly move through assumptions that lead to population health. And then, of course, realizing that this is in addition to, not instead of, great individualized care. All of this, of course, is also speeding up quickly. Not just doing better, but quantitatively, demonstratively doing better for less money. For instance, the whole health system running a very healthy 5% margin wholly on Medicare reimbursement or less. And at the same time, wholly at risk and transparent for the outcomes and the expenses associated with that care. That truly is a new system, a new future. This does lead to certain obvious questions. So if we have to deliver better for less money, we have to know things that didn't used to matter and answer questions we didn't used to ask, and also figure out how to address them constructively, such as, what is my panel? Who are my patients? And what is my overall risk profile? Who are my sickest patients spending the most money? And how do I adjust? How do I develop care pathways for those chronic conditions and effectively engage those patients? Realize as we ask that these questions really aren't at all obvious. These thoughts really, for most of us, is the culmination of years of system experience, individual work, and thought. We didn't come to this place where we are suddenly. And as we start to build programs, build dashboards, report metrics, try to improve the quality and reduce the cost, all of us doing this work on this call are probably starting in the middle of a conversation that most of our practicing physicians have really not benefited from. And we need to remember that and take that into account in our work. So a given physician's perspective of his or her work changes dramatically. The traditional view of your work is one patient at a time, one face in view, 25 or 30 times a day, day by day. The new view is not just one patient at a time on the left, but at the same time, simultaneously, a view of the whole population and how they subgroup and what patterns emerge and form. And that isn't, unfortunately, an either-or, it's a yes-and situation. So individual patients and patient care one by one each day is necessary, but not sufficient for care of a population. And this particular dual mind view, dual understanding of your work is not is very uncomfortable, and it's not intrinsic to how physicians are trained or think about their work. To provide this individual care and health of a population, it does require some fundamental changes in care paradigms. Physicians are very expertly trained as skilled craftsmen, personally, uniquely treating one patient at a time, day after day, almost as a unique craft or art. And what we need physicians rather to do, of course, is treat not just one patient at a time today, but treat all patients all the time. And to do that absolutely, fundamentally requires data that's actionable and accurate and timely, and a team to help manage that data in the population. One of my favorite quotes from Paul Grundy is that for a culture to be ready to be grounded in data, you have to also be ready to be grounded not in autonomy. And that's a very difficult step for physicians. There are other major shifts going on here that I categorize as personal level or practice level or system level. First is at the personal level, the view of our work, the paradigms are changing from physician to team, from pedigree to data, and from reactive, always catching up, to proactive. At the practice level, we move from reactive to proactive, from episodic to continuous in our care, and that's just classic Toyota management flow, from individual to population basis, and then from information being siloed and owned to being transparent and pushed across all sites of care. And then lastly, from an electronic record to an interoperable information system. And then finally, at the system level, from episodic payment to comprehensive or blended payment. These things at three different levels of perspective change the whole foundational culture of the practice of medicine. So challenges abound. This work of changing culture is very, very hard, and something that is not often realized is it's very personal. There's always the challenge of an individual physician or team just reverting to the status quo, deciding for them personally the pain of change is not exceeded by the pain of status quo. There is resistance to team care. There is certainly change fatigue. There's a lot of moving pieces in healthcare today, and the list of projects and priorities is virtually never ending. And there is a reality that our people, tremendously bright, motivated, and wonderful, really can only manage so many things at one time without change fatigue. There sometimes is a lack of a clear mission statement or roadmap. I find we do a pretty good job of describing some of the why and of where we're trying to get to, but it's harder to draw an understandable roadmap of how we get from here to there. Sometimes there's insufficient investment of IT resources, and without actionable, timely, trustworthy data, almost none of this is possible. And lastly, physician compensation can be a challenge and a burden to overcome, especially if it is not aligned with this transformational and value-based work. So ultimately, you realize that culture change takes place only slowly and gradually. It's not a revolution, and it only grows in fertile and prepared fields. And to some degree, at the organizational level, that is our challenge and our response is to build the systems and the culture to prepare the fields for our people to flower and flourish. Now, when you look at change, I can't help but think of two of my favorite quotes from modern masters of change theory. The classic from Deming, which I found useful in individual interventions sometimes with docs, that realize change is not necessary because survival is not mandatory. So if our systems are all inexorably changing and adapting, and there's a given doc or a given team who doesn't want to come along, that has certain implications that just need to be discussed, in a supportive manner. So now let's turn our attention to technical versus adaptive change. And this isn't necessarily new. But I find it's helpful to kind of keep it clearly in mind as we think about transforming our cultures to take on population health. So originally, Heifetz and Linsky back in 2002 distinguished very clearly between technical and adaptive changes. So a technical challenge or change is a problem where the answer is known or at least knowable. And so the solution is simply a tool, a process, a policy, a form. It's have a committee, define a policy, change the form. That's a technical challenge. But there is a whole host of problems that aren't amenable to an authoritative solution or the answer, the solution is not known. These things require new experiences, new experiments, new discoveries. We call them adaptive challenges because they require this idea of adapting and changing at numerous places in an organization at the same time and learning into the answer. We don't know the answer, but we will experience the answer as we change and adapt together. And that's a really key concept. Another final thing to realize about adaptive change is the sustainability of the change once it's accomplished depends wholly on the people who have the problem internalizing and living out the change solution. So it's not something that's just, a policy, a process, generate data, and then track it from a centralized position. Adaptive change requires the people finding the solutions, living the experiences, take group responsibility for maintaining that and sustaining that. Because those adaptive changes do fundamentally ask people to question and even refine aspects of identity, experience uncertainty. It often challenges people's habits and beliefs and values. If we accept we don't know the answer, but we're just going to try things, that can be very threatening. And so sometimes there is a sense of loss that's important here, and it's no wonder that people resist, doctors resist, if we're asking them to question what they're doing in a way that threatens essentially self-image. So this adaptive change does come with a great deal of resistance, overt and covert, and sometimes we do it to ourselves because we are confusing what is an adaptive challenge for a technical challenge. And so if you're approaching a process that really takes a change in culture and the solution isn't necessarily known, for instance, in my individual setting with my staff, my population, my local culture and economics, what is the exact perfect model for a high-risk care management strategy and bridging that from inpatient to outpatient care? No one knows that answer yet. We have to create it and discover it. And if you approach that from the perspective of get a committee, decide a policy, and implement a tool, you're approaching that like a technical challenge, and that often is going to not work out. So adaptive change leadership, as you approach this, involves describing a vision and a purpose, really describing the how in a story that people can rally around, create a safe environment for that experiential change and experimentation, gradually raise the heat on the system so that the change continues to roll onward and advance, acknowledge losses, losses of autonomy perhaps, losses of personnel who aren't interested in going where you're going, that sort of thing. Differentiate self versus role, and this is really important when people are fundamentally challenged about, such as, I'm a good doctor because I try real hard. Well, this is moving into defining good physician in different ways, and that's very self-threatening. We want to help differentiate self-worth and self-identity is different than the role you play in the system. And then lastly, and most challenging often, is to orchestrate conflicts, to use conflicts as energy in the system to continue driving improvement as opposed to avoiding conflict. It's interesting, and this is from Harris Interactive, that the more senior level leaders like CFO, CEO, board members are uniformly in agreement basically that significant change is needed to address the financial challenges in healthcare today. whereas the hands-on care staff, from physicians to subspecialists to nurses, are much less in agreement. They're not too sure that significant change is needed. And I think that's just a matter of perspective. And it's interesting, however, that also the same Harris Interactive poll, that physicians, when presented with the dominant different possible models of change, overwhelmingly choose the one that most dramatically impacts day-to-day workflow, which is the patient-centered medical home. And the medical home is fundamentally adaptive change for most standard practices. And that makes me wonder a little bit if physicians are just familiar with the term and the concept when they took the survey, or if rather it's at some deep, instinctual level, realize that what we need is really a redesign of how we deliver care, not just playing with the edges of the financing, which is often how the episode-based payments, ACO, and global payments are perceived. If that's true in your system and that's recognized, that instinctual level understanding that we can do better, though we're not sure what that looks like, may allow you to tap into that innate drive to do better for each patient as a change principle. Dr. Mashashari, our former ONC coordinator, had this wonderful quote about flipping the practice, flipping the hospital, flipping the economics of our whole system, which is what is happening now, is not something that can take place in 8-minute visits. And that is unequivocally true, that we are in the middle of a cultural sea change. And we need to make sure that's given appropriate weight in our health systems. We know often precisely where we're aiming. We're aiming to get our ACO diabetes composite measure above 6% in 1 year and above 10% in 3 years. But unfortunately, people aren't darts. People are wonderful, beautiful birds that have their own minds and fly. No matter how you throw them at the bullseye, they flap their wings and go where they will. And so the challenge here is to convince the birds that they want to fly at the bullseye. Physicians have a pretty acknowledged set of personality and personal characteristics, and that this is not being critical or demeaning. I am one of these. This is just recognizing what we have. Physicians are, in general, fairly compulsive about their work and a bit perfectionistic. That's how you survive medical school. Physicians have a high need for autonomy, almost instinctually want to direct things and resist being managed or directed. Physicians often resist external controls, have a very high internal locus of control. Physician self-esteem is primarily through work and outcomes as self-defined, and often physicians are fairly sensitive to being criticized. These very characteristics that make effective physicians work against succeeding with change. It's very hard to change those fundamental personality structures, however, and that those are the strengths that we should be working with. Culture is defined as the beliefs, the customs of a particular society or group in a place and time. Another way to think of it at the organizational level is a way of thinking, behaving, or working that exists in a place or organization. So I once heard a quip from a senior administrator that seems appropriate at this time, who was expressing frustration that just as soon as we start buying practices and employing doctors, they start acting like employees. And unfortunately, we need physicians to be both, to essentially straddle the two cultures, to be driven and self-motivated, insightful, dedicated professionals in that model, while also being up-to-date and cognizant of organizational goals, committed to systems processes and information, and willing to spend time on the relevant system activities, whatever that may be. All of that requires essentially giving up some autonomy, or some autonomy. And that's really, whether it's a lot or little, is an issue of perspective. From a physician perspective, autonomy is generally seen as an all or none situation, that you either have autonomy for what you're doing with your patients or you don't. from a systems perspective, if you work for a system or a large company, you frankly have a more nuanced view of autonomy, and you participate with and subordinate your autonomy to group process and goals in this group of areas, and in other areas you have more full autonomy. And that's a level of sophistication that sometimes physicians don't really fully understand. So it's important to realize physicians already have an established and deeply entrenched culture that kind of reaches its maximum fulfillment in single and multi-specialty group practices, where all decisions, even at a business level, are made by the physicians, and those groups have often been very, very successful. Coming from the population health and health system perspective, however, virtually everybody working in those situations come with a system culture, and they're very different. In the system model, or clinical integration model, groups lead to decision-making that's then often blessed at some level. Work and processes are externally defined. The time horizon is often quite long, measured in years. Boundaries and impediments to various things, given resources, budget, time is often common. Goals are very unified and often proscribed for you. Actions are often delegated to others. Motivations are often external, and improvement is something that you define, you measure, and you improve over time. The professional model, which is the backbone of physician culture, however, has autonomy is the mode of decision-making, and all work and processes is self-defined. Physicians do what they need to do for a given patient every day, one at a time. Success is defined subjectively and changes from patient to patient and time to time. The time horizon is often short, just this patient for the next visit. Boundaries in a given exam room is fewer. Goals are often disparate, and what's an appropriate goal for one patient is not considered an appropriate goal for another patient, so goals vary dramatically. Actions always arrive from the self and are self-driven. Motivation is not only not external, it's almost purely internal. And improvement is not a process involving measurement. Improvement is study, vigilance, diligence, and hard work is what leads to improvement. In many ways, that is diametrically opposed to the mindset and the actions we need to move towards population health. And as Deming was known to quote, that working harder is the worst improvement plan. And unfortunately, that's the default for the physician professional model culture. So we get to where Dr. Gawande's classic quote is very germane, which is that we train, hire, and pay doctors to be cowboys, but what we really need are pit crews. And really what this is another way of saying that our training models and compensation don't line up with our ultimate needs. And so the culture of medicine, of physicians, rewards one way of being in terms of pay, personality, and prestige, when what we need, what our society needs, is something very different. And again, back to culture change only taking place slowly in prepared fields, even if we change the pay and the prestige overnight, it takes time to grow a field of flowers, or it takes time to change cowboys into pit crews, and that's often a long time. From a chief medical officer perspective, our analytic tools tell us where our gaps are, but they say nothing about how to actually engage or solve the problem. So data is immensely powerful. Paul Grundy said at a prior Vital Executive Summit, data does for the mind what X-ray does for the vision. And that was really an aha moment for me. But data, as you quickly learn, is only necessary but not sufficient. Without it, absolutely nothing changes. But with it, you have the beginning of change, but nothing more. So data is the place you start from, not where you end up. So here's a best use case from Insight and Coordinate using a diabetes model, and this is how actionable, real-time, reliable data starts the conversation. to moving towards population health and as a lever to change the culture as you move towards strategy. So you have reliable data that you stratify by care gaps and risks, identify patient groups. Each group has unique levers, plans, and priorities that you engage your care teams and your workflows in, and then communicate with those groups appropriate to move their health care. That type of analysis that focuses on the well-being of individual people, at the same time clearly identifying groups and letting you plan targeted priorities, is a way to intrinsically use that professional model culture of physicians and start linking them into the professional health population health mindset. Often there's also a bit of a bubble phenomena, and probably everybody in some part of their life has been in a bubble, whether it was in college or in medical school or early marriage, family time, etc. But physicians often just see the inside of the office as their environment. So inside the circle, the patients that come in, the staff you work with, the four walls of your office, and everything out there, whether it's prescriptions to the pharmacy or the health system you're part of, really is external. And this speaks to broadening that circle to understand that care management, patient engagement, how the business and revenue cycle flow in and back to your practice, and how advanced technology like telemonitoring can extend your walls are important views to bring down to the physician scope, really expand their scope of view to include those things. Next, I want to turn our thoughts to 3 or 4 views of psychology that leads to resistance to change. Why don't physician cultures change quickly? Why don't doctors race to be first in line for a new process or a change? And the first, and the one maybe I find the most powerful, and what started kind of this whole exploration for me, is cognitive dissonance. And this came out of realizing when I'm trying to, empower and help a physician prove they're delivering the great care they think they are and identifying the areas that they're not by providing data. You actually get a fair bit of anger, sometimes some rejection, sometimes a wall goes up without any further communication. And it just led me to wonder that those were very personal and deep responses to what seemed to me at the surface level to be really pretty clear, and it's all about data, and the data is what it is. Well, this is because of cognitive dissonance. Leon Festinger was a very well-known psychologist in the early part of the past century, and talked about cognitive dissonance being acknowledging, rather, that we have an inner drive to hold our attitudes and beliefs in harmony. And so cognitive dissonance is the feeling of intense discomfort produced in the combined presence of 2 thoughts or realities that don't follow from one another, such as, I know I work real hard, I'm a good, well-trained doc, I know I provide great diabetes care for my patients. And here is a set of data that is probably accurate that shows I'm not providing good care or best care for my diabetics. Those 2 things can't both be true, but they are. And when confronted with that situation, you get fairly intense dissonance and emotion. When you're in a state of this cognitive dissonance, trapped between 2 realities that are mutually incompatible, you feel disequilibrium, and that's expressed as frustration, embarrassment, anxiety, dread, guilt, anger, pretty much the whole range of human emotion. And Festinger said that, quote, the greater the discomfort, the greater the desire to reduce the dissonance between those 2 elements. And this really, for me, shed light on why we often get irrational or even, frankly, overtly destructive behavior in a situation when docs are presented with a change opportunity, we say, or data. Now, there is a way to use this knowledge to reduce cognitive dissonance, and there's really 3 basic strategies. One is to focus on a more supportive belief that outweighs the dissonant belief or behavior. The second is to reduce the importance of the conflicting belief, and you make a way for the one that's conflicting is just less important over time. And then thirdly is to change the conflicting belief so that it's more consistent with the other belief or behavior. And one way to do that is, and this is where you manage and orchestrate conflict, one way to do that is to bring this out. When someone is, by essentially mandated behaviors, when someone is forced to do something publicly that you privately don't want to do, you create dissonance between what I think, I don't want to do this, I don't want to measure my diabetes, I don't want to be transparent with my quality data because I think I already do a great job and it's a waste of time. And so when you mandate that behavior and you have internally, I don't want to do this, and the behavior says, I did, it's done, and you can't take it back because it's in the past, you can present a person with the options that you either change your belief or you have to change your belief because you can't change the behavior. The behavior is mandated. Not only is my diabetic care measured and presented to the whole group, it's going to be measured and presented to the whole group every quarter from here on out. I can't change it. It is a reality. So all I'm left with to get rid of that dissonance and discomfort is to change my belief structure and what I think about that. Next is we look at comparing our transformational work with the stages of grief. And this has been really interesting to watch this play out. This was another aha moment for me. And I saw this as I've been engaged with medical home teams in transformative work over the last 2 and 3 years. I have been able to see and observe and watch teams move through the stages of grief at different times. And so this plays out with culture on a large scale and with physician and care team response to data and work change on a small scale. And everybody knows the 5 stages from Kubler-Ross's 1969 book on death and dying, which was inspired by her work in terminally ill patients. So denial, anger, bargaining, depression, acceptance. And most of us remember that you can move through those 5 stages in different sequences for different people, and even some of them simultaneously. So they don't have to be serial or sequential. You see this with data in particular. So the first level is denial. The data is wrong. You're wasting my time. Come back when you have it right. Or this isn't important. Don't bother me with the data. Next is anger. The data's not right. How dare you measure that? How can you possibly question my quality? Then bargaining. Well, the data doesn't seem right. Where are the data fields pulling from? Did you consider this? What are the exclusions to the data? That's all the bargaining stage, starting to come to grips with that. Then depression stage, so the data is right. I'm really not doing as well as I thought in my diabetic care. And finally to acceptance. Wow, that data is really convicting. I know it's probably accurate. How can I use that data to help Mrs. Smith, who's coming in tomorrow, as well as to help my whole group of patients? And so stages of grief, and there's probably ways to facilitate and help our physicians and care team members work through that a little bit. And then lastly is needs theory. Needs theory is based on, is one of the 4 dominant theories that explain how individuals act in organizations, and it's based on Maslow's hierarchy of needs at the individual level. And this is to realize that basic physiology, clothing, food, water, shelter, warmth, and security issues like can I feed my kids, can I get them educated, do we have a roof over our heads, those and a lower level of social interaction are satisfiers. Those are basic safety and security needs of our psychology and our selfhood. And then higher affiliation, what group do you belong to, power, esteem, achievement, self-motivation, what Maslow calls self-actualization, those are motivators. And it's interesting to me that in a typical organization, the encouragers we use, recognition, position, salary, committee chairmanships, that sort of thing are motivators only when the basic requirements of safety and security are met. And so that is to say that if your docs are worried about, fundamentally worried about their salary, fee for service is going to change. We don't know what it's going to be. Worried about their staff, we're collapsing expenses and we laid off 10 people. Can I keep my nurse? That what used to be important and how we define good care, which was individualized excellence, is no longer sufficient. And there's a new definition that I don't really understand. Those are basic security things. And if those aren't met and dealt with, don't expect much motivation or response to public acclaim, perks, achievement, or really any self-motivation. And so this applies if you've got a physician culture, a practice culture that is just so stressed about all the many things moving that it is hard to get motivation or movement on things that are higher level. And then lastly, I really wish I had a chance to thank the authors of this recent study in Annals of Family Medicine, which is just classic, that reported a study looking at 23 very high-functioning primary care practices and talked about in search of joy in practice. And it was groups that had lived from the physician-centric autonomy model, professional model of work distribution to a shared care team model. And the top 5 innovations, and this article really spoke powerfully about rediscovering the joy in practicing medicine. The top 5 innovations were as listed: proactive planned care in advance, moving to proactive, not reactive; shared clinical care and decision-making among a team; sharing clinical tasks, that's team care, height of license stuff; improved communication and efficiency; and improved team functioning, workflow mapping, team meetings, daily huddles, that sort of thing. If you look at all 5 of those are all about being planned, prepared, and communicating in group process. In other words, a pit crew. Planned, prepared, practiced, communicated with a group. That describes a pit crew. And when you apply that to the impediments or the challenges in culture change that we have today that we've touched on, realize that there is tremendous safety and mutual support in a group. Any second grader knows that. A group can, touching on stages of grief, a group can powerfully and quickly help process grief and loss effectively. Every hospice I've ever been associated with as a hospice medical director didn't do grief support on an individual basis. It was always in a group. Next, a group has give and take, is able to change and adapt, fail and improve. That's adaptive change. That's learning into the answer. A group collective wisdom, experience, and insight is much more powerful than an individual. A group can reframe good, can focus on more supportive beliefs, can help reduce the beliefs that are conflicting so that it's consistent with other beliefs, and help reduce cognitive dissonance. So I urge everyone to consider down at the patient care level and embrace group team-based care. I think that may be the easiest lever to move our care teams and our care systems in the direction they need to go. Advancing strategy and culture are not incompatible, but they're different. So strategy classically is goals, processes, budgets, timelines, plans, feedback, and response. Advancing strategy is really the goal and the mechanism of an organization. But as we've just talked about, physicians have a powerful and deep culture, subculture, that is not likely to change because of the nature of how physicians are chosen and trained. And they don't necessarily respond to those things. But advancing culture is more about explaining the why and pointing out the way, setting a big, hairy, audacious goal, asking important but hard questions, communicating and over-communicating, organizing resources, reducing barriers to people trying, empower those that try, and aligning incentives. Advancing culture is more important. Once the culture is advanced and moving, then strategy is how you fill in details, is how you make the sticky bits fit together. Physicians, I have found, will respond to the elements of advancing culture. And when you do that, the strategy is just how you make it happen. So ultimately, you get to a balance. And you need both top-down direction and change as well as bottom-up. And this is the way you use the professional physician culture, professional model culture, to the benefit of the system and the patients you take care of. And this is that from bottom up, the things that happen in the office, in the exam room, those cannot be imposed. That's where the physician instinct to resist direction, fight for what they believe the patient needs kick in, and you just can't get crosswise with that. But supporting teams with credible information, actionable data and analysis, helping reduce barriers so that people can do the right thing in the right way and make it hard to do the wrong thing or in the wrong way, and then providing the ability to respond. That gets you meaningful change from the bottom up that physicians can latch into. From the top down, we need an organizational commitment to priorities, to resources, to budget, to providing data, and then just make those things happen. Of course, it's a lot easier said than done, but that leads us to a way forward. And this is the way forward writ large, and the next slide will be on a little smaller scale. So the way forward is to remember adaptive change and learn into the answer. If you know the answer or think you do, you're in technical change. And don't be fooled by a tool. The work we have to do to realize population health is predominantly culture change. There's not a tool that fixes a care model of keeping congestive heart failure patients out of the hospital. That's about how you see and approach your work, and that's adaptive. Appreciate what physicians bring to the table in their professional culture and model, and don't try to change that, but build on that. Next is understand cognitive dissonance and then reframe it. Whenever you've got a committee or a doc who's angry or unreasonable, it's not that it's personal, and this took a while for me to learn. It's really not personal. It's just that whatever I am proposing or bringing to them threatens their sense of self-worth, self-esteem, self-identity. And the anger, the frustration that comes out of that is because they're squeezed in the middle. And so consider that carefully. Maybe use that working theory to mandate compliance in some small way with incontrovertible data, and then help reframe the issue. So I call this seeking the power of yes and how this works is, yes, that diabetic data is certainly disappointing, and it's not that the quality that's the quality of your diabetic care. It's that the EMR doesn't capture all of your work that happens outside of our system. Our EHR doesn't allow you to easily document your quality, and we've really not surrounded you with the right support systems yet. So yes and invites engagement, whereas yes but argues and separates and kind of demeans. I've tried very hard to strike yes but from my vocabulary. The next is supply the Maslow satisfiers and link to motivators. So this is really probably most critical with salary-related issues. As you transition to value-based care in population health, we're going to need to phase in changes aligning comp to values and goals. CMS, I would propose, has this completely figured out. You initially, and this has been seen in PQRI and meaningful use, you initially pay to participate, and then you are paid to perform at a very, very, very low level that's very unthreatening and harmless, and then it flips to suddenly you are penalized for not participating at some minimal level, and then thresholds just keep getting ratcheted up. And that, none of us liked meaningful use, yet we've all basically complied, and it has worked. Then lastly is to embrace clinical teams and help expedite group grief. We mourn, especially if you came from a really robust, rich group culture, and you're now part of a bigger health system. You've lost some autonomy and some decision-making. Our care teams and our docs have some grief and really look back longingly to the world that was. And clinical groups, they're really the basis of team care and population health, help expedite that grief, offer support, and offer safety. Now, written more slowly, we can mandate workflows to create data and then use that to help manage cognitive dissonance. I would say just deliver IT, and that's the beauty of FITEL And that incredibly responsive, robust system is it allows you to have actionable information and data at the physician level that then you can work from. You do need a vision that's widely communicated, grounded in quality and patient well-being, because those are the things physicians can hook into. Let clinicians choose the metrics to some degree and then just deliver the dashboard. The way forward can be committed to transparency of data. Physicians are certainly competitive and self-introspective about how they look to their peers, and nothing enables and empowers that more than transparent data. Realize that many of the early wins in organizational transformational work are things the organization can provide and start, such as improving message and phone flow, reducing complexity, care coordination, those sorts of things. If you provide some early wins, you show how managing workflows and engaging data constructively can really start making things better. Often physicians will start using their culture, their motivations, and meet you at that place. Realize, and this is a little challenging, realize that pushback is good. If there's pushback, at least there's traction. That means the concept, the data, the workflow is engaging the brain. People are thinking about it, and you can work with that. That's far better than just the wheel slipping. And the next a mantra is you move initially to when you provide data, doctors feel like it's competing, and then it can be reframed into a cooperation, and finally you move into a holy grail where it's collaboration. This is a very germane and cute way to end our talk today.
This cat herder is my great-grandfather. He's the first cat herder in our family. Herding cats. Don't let anybody tell you it's easy. Anybody can herd cattle. Holding together 10,000 half-wild short hairs, that's another thing altogether. Being a cat herder is probably about the toughest thing I think I've ever done.
I got this one this morning, right here, and if you look at his face, it's just ripped to shreds, you know?
You see the movies, you hear the stories. I'm living a dream. Not everyone can do what we do.
I wouldn't do nothing else.
It ain't an easy job, but when you bring a herd into town and you ain't lost to one of them, ain't a feeling like it in the world.
Well, that is cute. We would never want to refer to our valued colleagues and friends as herding cats. Instead, I'd propose that we are helping teach eagles to fly in formation. I appreciate the time. It's been a pleasure to talk with everyone today, and I'll be happy to take any questions.
Okay, everyone, it's time for the Q&A. You can submit your questions using the chat panel located near the bottom of the control panel. So please submit your questions now. Okay, we've got our first question. How can population health management programs support the growing trend of value-based purchasing initiatives?
Well, in a very real sense, population health is the underpinning, is what is going to make value-based healthcare possible. Without managing populations, without risk stratifying, there's not going to be any improving quality or reducing cost. And so it is the tool, it is the lever that makes basically value-based healthcare possible.
Okay. With the topic of population health, many people think of diabetes, obesity, and blood pressure. Are there other conditions we need to be concerned about?
Well, sure. Really, population health isn't disease-based. Realize that all these people are more than the sum of their diseases. And so true population health is looking at an entire person, not just their disease states. The social environmental issues and barriers come into play dramatically. And so the risk stratified care management using population-based data lets you take all those other things into consideration that are more than just a collection of diseases.
Okay, our next question is, what are the advantages or benefits that various stakeholders will realize from population health management programs?
Sorry, Tammy, can you repeat that one for me?
Sure. What are the advantages or benefits that various stakeholders will realize from population health management programs?
Well, I mean, the whole point to population health program is to build a system where it makes it easy to do the right thing and hard to do the wrong thing. And so it comes down to better healthcare outcomes and reduced costs for everybody. And so everyone involved has impact. It's a rare win-win-win that every stakeholder gets something that's important. Okay,
great. All right. Let's see. I think that might have been the last question. It is. So if anyone else has another question, please submit it right now. We got a couple more minutes. If not, we'll conclude. Okay, it looks like there's no, well, hold on. We've got another one that just came in. How vital do you believe the integration of behavioral health into the primary care system is?
You know, that's a really, really interesting and powerful question. I'm glad somebody asked. I think, frankly, the true population health, managing a person, helping improve a person's health and groups of people's health more than some of the diseases, means this artificial schism between mental health and physical health is going to have to collapse and go away. So I think integrating behavioral health and primary care together is tremendously powerful and is probably going to be necessary to really achieve the full aims and promise of population health.
Okay, we have another one. How can we communicate these changes happening in practices to third-party payers to negotiate value-based contracts?
Boy, a really insightful, interesting question, which probably is going to be different market by market. So, in generalities, I think if you have solid data to go to payers and show how they're going to do better and they should help you do better with the data that you bring to the table and the groups that you manage, I would hope most payers respond to that. I think it's interesting that in healthcare, we have long been frustrated with, health plan-centered chronic disease management or care coordination programs, for instance. And we've said for decades, if only they would give us the money, we would be able to do so much better on that. And I think I'm noticing across the country that health plans essentially are planning on getting out of the risk business. And so I hope we were careful what we ask for, because I believe that in the very near future, the risk and the pay for that risk will be coming down to providers and health systems.
Okay. When working with doctors, what level of ancillary staff are more motivating? Admin, mid-levels, or simply an MD champion?
I assume that question means more motivating for the care process. I think admin support in terms of budget and plowing barriers. So the admin support at a high level is critical, because that gives right and credence to the change process and help set the big, hairy, audacious goal. I think a physician champion is important because it gives other physicians someone they can go to with their frustrations. Now, that physician champion really has to have a pretty insightful and transparent look at the process that's planned and how doctors fit into it. I think, though, it's that third piece. It's not, I wouldn't say staff, it's the clinical care team. That is, in my experience, the most powerful change agent, and it's the group that lets you reduce all of those resistances to change, essentially with one structure.
Okay, we'll take one more question since we're about out of time now. How do physicians and providers react to the material on cultural and organizational change? How can their readiness to change be gauged and herded along?
Another great question. I think there are tools out there and a knowledge base of how to do a cultural assessment and then a cultural change plan. I mean, many of the change plan tools that are out there, whether it's GE Change Acceleration or Lean, I mean, there are many change management strategies that can be applied to looking at the culture, assessing it, and figuring out a change pathway. Repeat the question for me, Tammy.
Sure. How do physicians and providers react to the material on cultural and organizational change? How can the readiness to change be gauged and herded along?
Yeah. On the care team level, there actually has just been and I think the most fundamental cultural change for physicians and staff is the pivot from autonomy to team, from reactive to proactive, from episodic to continuous. That fundamental together, the group of people that work together in one area take care of patients together, that's a care team. And there was in family medicine, November, December 2013, there was the first tool I've ever seen from this, called Measuring Team Development in Clinical Care Settings. And it actually has a tool, a team development measure that is statistically validated and reproducible. It has good test metrics that lets you assess the stages of team development and change in a care team, from a very early initial development stage of no team development all the way to full team development, culture firmly in place. So there is a new tool that is possible to help at the care team level assess readiness to change and where the culture is now, and then it would help you guide, program steps and the metrics at each level of development as you move towards a fully realized team model based on that assessment tool. So that's been helpful to me.
We're getting asked, can we send the reference with the team change too?
I'd be happy to do that. Sure, I'll give it to you and let you send it out.
Great. Perfect. Okay, everyone. That's all we have time for today. Thank you so much, Dr. Mills. It was very educational. So that concludes our webinar. Thank you all for joining.